Myopia management is an evolving area of clinical practice, and there are certainly more interesting updates to report, as well as posing some clinical dilemmas for you all. Out of courtesy, our role is to ensure you are given honest advice. We must agree a plan together, we must not dictate one. I would also like to emphasize the level of experience we have in myopia management. Consequently, here is my 2026 update. I want to start with this bar graph from the My Kids Vision website showing the choice and effectiveness of virtually all the options available for controlling myopia. Let's dissect it. At the very bottom, single vision contact lenses and spectacles are totally ineffective at controlling this. At the top would be our holy grail of 100% cessation of myopia progression. Now, all the premium products are evenly matched for effectiveness and demonstrate a 50% reduction. Orthokeratology, MySight contact lenses, both Stellest and MyoSmart spectacle lenses are definitely our recommended optical products, while 0.05% atropine is the optimal medical intervention. Next on the list is multifocal contact lenses, executive bifocals, and a weak atropine. Now, I was actually surprised to learn executive bifocals have a reasonable effect, but they would certainly be somewhat cheaper. And finally, the least effective with only 28% reduction is Zeiss MyoCare and MyoLess spectacle lenses. The Zeiss lens at least maintains the circumferential treatment zone, meaning all the peripheral retina is treated. The MyoLess is in effect a complex varifocal and therefore, like the executive bifocal, has a limited effect zone. This will all become clearer later. The ethical problem here is that these particular products are not as good at achieving the very thing we're trying to sort. The question is, should we even offer them? Well, I think yes, and we do use the Zeiss lens simply because they are less expensive and certainly a lot better than nothing. So again, courtesy demands we explain pros and cons and agree a plan with you. So a little background knowledge first. Why do some people even become short-sighted? Well, we're actually all born slightly long-sighted because our eyes are a little bit short or a little bit small. So as we grow, our eyes grow in length and we become less long-sighted, which is absolutely normal. Ideally, when we've stopped growing, images from a distant object are focused through the optical system perfectly onto the retina, giving a clear image. People destined to become short-sighted start off long-sighted as well, but for reasons we are now really starting to understand, the eyes don't stop. They grow past the neutral point and keep on going. As the short-sightedness progresses, we effectively have to play catch-up with stronger lenses. But ultimately, once the person stops growing at about 18, 19 or 20, the eyes stop elongating and then the patient enters a stable period. The goal of myopia control is to slow down progression during the growth phase. Now, there is an evolving debate. If we know a child is at risk, perhaps both parents are myopic, and we have noted a rapid drop in long-sightedness, should we offer myopia control even though the child is clearly not short-sighted yet? ESLAW have even prepared a table with risk levels with this debate in mind. Now, this is definitely not a decision for a clinician to dictate. Trust is essential, and time must be allocated to explain a parent's concerns. Then a joint decision to treat pre-myopes may be agreed. Since ocular elongation is the cause of short sight, the only true measure of myopia progression is recording eye length. Simply recording an apparent change in prescription via a routine sight test is not adequate, as it is very easy, unless extremely careful, to over-minus young people because they simply focus their eyes. Now, we rely on retinoscopy to ensure that this is avoided, and the link below describes further the essential clinical skill. But the gold standard for monitoring myopia progression is biometry, which measures extremely accurately the axial length of the eye, which is essential. Now, I'd like to run through our clinical history on myopia management, which I'm happy to say reflects the highest performing strategies. We never wait until something's been out for a while before joining the bandwagon. We're there at the beginning, and Myopia Control was no different. Experience is valuable, and we do have a lot of it. So I will be banging the drum a little bit for errors. Now, the first thing on the block in 1996 was orthokeratology. Now, back then, it wasn't marketed for myopia control. Most of us noted an effect, but it was simply anecdotal evidence. But we were a founder member of the British Orthokeratology Society, so our experience in the use of these complex lenses is extensive. Then, in 2015, came my tipping point. At the time, myopia control research had gone on for decades, but the results were always a bit woolly. But in 2015, at the Optometry Tomorrow conference, Professor Bruce Evans indicated there were finally viable options for patients to consider. I went straight back to the practice and we immediately commenced myopia control services. So while in 2015 the evidence was indisputable, there was no licensed product available to fulfill the goals. Fortunately, we had multifocal contact lenses, the sort of lenses a 55 or 60-year-old would wear to help them read. And just like orthokeratology, they weren't designed for myopia control, but they happened to fulfill the needs. So apart from rebooting ortho-K as a myopia control option, we also prescribed a specific multifocal contact lens off license. They're not quite as effective as the premium products, but we actually still use them for very unusual prescriptions. And in 2018, MySight contact lenses specifically designed to control short-sightedness were introduced. And then finally in February 2021, Hoya introduced their MyoSmart spectacle lens to Britain. Now, we had been anticipating this lens for some years. It's complicated and you had to be accredited with 100% to be able to prescribe it. So I'm really proud to say in February 2021, within a week of its arrival, we were prescribing this game-changing lens. Game-changing because all prior options involve contact lenses, which do carry some clinical and lifestyle constraints. Then in 2025, we were also able to add the equally effective Essilor Stellest spectacle lens to our portfolio. And in 2026, the licensed drug atropine will at last become available to medical optometrists. And as medical optometrists, we'll be one of the only practices in Northumberland allowed to prescribe these licensed drugs. Now, I'm going to expand on those last four later, but first I should finally explain the theory of myopia management. Actually, before doing the more technical stuff, I want to reintroduce you to the 30-30 out rule. It's a bit of lifestyle advice. Always hold prolonged near tasks more than 30 centimeters from the nose. And take small breaks at least every 30 minutes. When students are at school or university, they're rocking back and forwards between a whiteboard and reading tasks, so they're actually having lots of mini breaks. But when studying at home, their focus may not deviate from the PC screen, so you need breaks. And then out is spend school breaks outside, because sunlight has been shown to be beneficial. People who spend more time outside have less progression. However, I would stress the effect is extremely small, but it's like eating a healthy diet. It makes perfect sense just to follow the 30-30 out rule. How to stop eye growth is a sole goal in stopping progression. But you've got to understand there's genetic and environmental factors also implicated. So the realistic claim is we can slow progression of short-sightedness. We cannot stop it or reverse it yet. Now I say yet because the advances we've witnessed in the last 6 or 7 years have been remarkable. And in fact, in the MyoSmart clinical trial, 1 in 5 had no progression of their short-sightedness over the 2-year trial period. Now, okay, it was only 1 in 5 and it was only over a 2-year trial, but it just shows you how rapidly treatments are being refined and improved. So the realistic claim with all the premium techniques, that's contact lenses, spectacles and atropine, is to slow myopia progression by on average 50%. Now on average is really important. Some people get much better results. 1 in 5 people had no progression at all in the MyoSmart clinical trial. But it also means some people would get poorer results. So you can't say on an individual level 50% reduction is guaranteed. It means on average this is what we would expect you to achieve. So you might think, you can't stop it, you can't reverse it, I'm still going to need correction, so why bother? There are enormous reasons for bothering. There are benefits for every myopic patient. Short-sighted eyes are more prone to a range of retinal diseases, and for every unit of myopia we can reduce, the risk to the person developing problems is reduced by 40%. And that doesn't just mean if we maintained you, say, at -5 rather than -6. It also applies if a patient is -1 rather than -2. So at every level there is risk, and by reducing your myopia, we are reducing your risk. But also there are societal benefits. As more and more people become myopic, which they're doing, the long-term impact of these sorts of problems on the health service are enormous, and the costs are going to be huge for future generations. So we need to try to slow progression as much as we can. And this does emphasize the importance of using the most effective techniques for slowing progression. Over the years an eye can grow, a less effective treatment will leave more residual myopia. There are also simple lifestyle considerations above and beyond reducing risk of myopic disease. By maintaining someone at -2 rather than -4 would allow quite a comfortable reading distance. -4, you'd have to hold the book uncomfortably close. Now that might not seem important when you're only 20, but believe me, when you're over 45 it is. Equally, maintaining -1 rather than -2 would allow many people to potter around inside unaided. And no matter how outsidey we may think we are, we all spend a lot of time in enclosed spaces where nothing is that far away. Again, especially when you're older, unless you live in Buckingham Palace, being slightly short-sighted is really quite convenient. So what drives short sight? Well, we're now talking about an image shell. Now this eye is not short-sighted, as you can see. Light coming from a distant object is focused through the optical system perfectly on the retina. What's important is the entire image shell is contoured to the retina. So all of the retina is in focus all of the time. Therefore, this eye is not destined to become short-sighted. Now this eye is going to become short-sighted. It's not short-sighted yet. Distance imaging is still focused perfectly at the retina. But the image shell in the periphery is not contoured very well. So while the central vision is focused and the patient will not complain of any problems, the peripheral vision is blurred. Now you don't notice this because it's used for navigational vision and it doesn't have to be a high quality. But the peripheral blur drives growth. The eye decides it wants to grow towards the image shell to make it clearer, which drives it towards short-sightedness. And this is what happens. The eye grows in length to try to correct the peripheral blur, but of course it then makes the eye short-sighted and we have to correct it, which incidentally reconstitutes the peripheral blur. So the treatment aim is to draw the peripheral blurred image shell in towards the retina to ensure all-round retinal clarity, like that, which stops growth factors kicking in because the entire retina is in focus. Now this explains why the most successful strategies, both contact lenses and glasses, draw the entire image shell in around the clock to align with the entire peripheral retina. And clearly the executive bifocal and myoless varifocal don't. The first product specifically designed to slow progression was the MySight Daily Contact Lens. The way this works is the central part of the lens is pure distance, bringing everything to a nice focus at the back of the eye where you want it. The periphery of the lens has a different power profile and draws the peripheral retinal image in to contour to the retina, slowing progression. I have to say contact lenses make an awful lot of sense because they sit on your eye and move with your eye. So you get the full effect no matter where you look. With standard spectacle lenses, of course, if you look off axis, you're getting a different focus profile on the retina. This is why contact lenses were the first to come out. They make a lot of sense and they really do work. This is also a daily lens, which is important as they carry the least risk of infection for young people. They are an ideal lens. So, time now to introduce the concept of effect dose, which is really important. The effect dose is the term applied to the effective time on the eye, and the longer the time, the better the effect. So for any intervention, contact lens or specs, to achieve the maximal effect for myopia control, they must be the primary visual correction. If someone only wants to wear them on weekends, then you can't really offer them because they won't be worn long enough to have a maximal effect. And of course, this raises certain ethical issues. Do you really want your child to wear contact lenses all day, every day? Parents may want them to take them out on weekends or remove them when they first come in from school. So there are certain concepts here that need to be considered, and the parents must be heavily incorporated in the decisions. Now, the answer to that clinical dilemma came in February 2021 with the introduction of the Myosmart spectacle lens, and we now have the equally effective Essilor Stellest lens. So how do they work? Well, design variations aside, both lenses have circumferential treatment zones consisting of tiny lenslets, and these surround the central portion with the full single vision distance prescription. In the periphery, the lenslet distribution ensures a 50-50 split between lenslets and the child's normal vision. So it's not all blur out there. You've got 50% for each. Extremely clever stuff. Now the Zeiss MyoCare lens also has 360-degree cover, but for some reason simply doesn't perform as well. Now, the Myosmart and Stellest lenses are classed as medical interventions and must only be prescribed by accredited optometrists. Frame fitting and lens centration are critical and need to be dispensed precisely by a qualified dispensing optician to ensure the maximal effect dose. Now, while ongoing adjustments are important for all our patients, they're critical for the effect dose of these lenses. Ongoing adjustments anytime is an essential part of the service to you. And finally, the eye drop atropine has long been known to be effective in slowing myopia progression, but unfortunately it's only ever been available in 1%, which is too strong. Lower concentrations had to be prepared in a hospital pharmacy, making it impossible to prescribe in the community. But as of 2026, pharmaceutical companies have promised me they are producing this stuff specifically as part of a myopia management plan. 3 concentrations have been assessed, but only the 0.05% achieves the 50% reduction in myopia progression. There seems little point in prescribing the others. How would atropine fit into our treatment armoury? Well, first, as a second line management to add a bit of oomph to specs or contact lenses if they are not achieving the desired effect. As always, we already have experience in this strategy. We've been liaising with the hospital to prepare it for a patient, but it is a bit messy and rather expensive. But this hybrid approach has been very successful for the one patient we have used it for so far. But also standalone management. If 0.05 atropine yields an excellent result, and if it suits the patient or is more cost effective by sidestepping other options, this could be a first line management. We'll see how it goes. But of course, as medical optometrists, we will be the first in line to access these licensed prescription only drugs. Post 2021, our options to treat expanded. Previously, there may have been reservations about prescribing contact lenses to very young children. We would advise and perhaps decide to monitor very closely. But of course, as we monitor, it is progressing. So the spectacles and atropine allow us to get stuck in as soon as possible. And the range of optical and medical options now available allow us to maximize effect dose without disrupting lifestyle. If your child would like contact lenses, we can do it. If your child knows they look cool in glasses, we can do it. If for sport or leisure your child wants to mix it up, we can do it. If your child would benefit from all-day clear vision unaided, we have orthokeratology. And if your child keeps breaking their glasses, which is not uncommon, we could stick to standard glasses fully covered by the NHS and prescribe atropine. So for all ages, we should strive to fulfill individual lifestyle needs. The broad range of options now available allow us to do just that while maximising effect dose, which is as it should be. So there you have it, Myopia Control 2026. If any of the stuff is of interest to you, please make an appointment and we'll be happy to discuss it with you. Thanks very much.